and I'd like to thank whoever it was that accepted my abstract to allow me to come here. This is my first time here, and I have to say this is it's been a really exciting experience for me. I didn't even know this thing existed. Bill's been keeping it a secret from me for years, and he finally revealed that it does exist. This reminds me a bit of the old days of the DOE graphics forum. I don't know if you guys are familiar with that, but the Department of Energy used to get together all the people from, well, they still do, but I'm just not invited anymore because I'm not in the DOE anymore. So they don't tell me about their meetings. It's kind of a secret, well, it's not a secret. It's the DOE meeting across the labs of all their Viz folks. And it's informal, it's about this size, and people get together and they talk about the state of what's going on, what the challenges they're facing at their individual laboratories, but they also talk about their projects and what's new and what's coming out and what, you know, and then they play some cards, right, Bill? They play some, you know, no?
That's SIGGRAPH.
Oh, SIGGRAPH, sorry, I'm getting SIGGRAPH mixed up with DOE graphics forum. Anyway, that is a very valuable thing because it's a small group. A lot of times when you have a Viz component of a bigger conference, it gets sort of washed over. You know, the Viz talks they put at the end so that when people run over, they can cut the Viz guys because nobody's really interested in that anyway, except a few geeks like us. Anyway, so I've been at the University of Texas for about 5 years. Before then, I was at University of Illinois. I'm going to tell my story because I find when people give their backstory, it's fascinating. I like to hear, you know, all the different places where people came from and their journeys and how they got to where they are. It just makes me feel better about my journey, my own story. Anyway, so you get to hear mine now, since I listened to all yours. Where was I? I was at University of Illinois, right? National Center for Supercomputing Applications. Before that, I was at you know, you remember, Department of Energy, right? Yes, DOE, right? And there was a little bit of grad school in there too. Bill and I went to grad school together. Some basketball, a lot of basketball was played, right? So Bill and I and a guy named Pete Shirley, I don't know if you recognize the name. He was actually here, as a matter of fact, as a professor for a brief time in the 90s. Then he went on to University Cornell. Then went to Utah. He was at Utah for a while. Now he's at NVIDIA. He's a big ray tracing guy. So back in the early days, I knew a ray tracing guy and I knew a VR guy, and I did neither one of those. Bill was the VR guy. And then now, guess what I do? I do some VR stuff with the Department of Women's Health, and I do some ray tracing. But it took me, I don't know, 25 years to come around to actually doing that sorts of things. Anyway, before DOE, there was Northrop Aircraft Division. My basic training, undergrad and master's degree is in aerospace engineering. And then my PhD is in computer science, in numerical analysis, actually. So I came from the simulation side, like a lot of visualization guys do. You know, there's a lot of computational physicists and chemists and things like that who have to do Viz, and they gravitate toward it, and and they do some more of it. And it sort of sets the hook, and they get interested, and they end up here at the CAV conference. Anyway, right, women's health. Let's talk about women's health. I split my time at Texas between the Scalable Viz Technology Group, where I do ray tracing and support for the large scale high performance computing systems there. But recently I've taken a half-time appointment at the Dell Medical Center in the women's health group. And this is a total shift of what I do, right? I mean, you know, I came from the very defined world of computational physics, simulation. Everything is very, you know, well-defined and analytical. And then I went to that. That's my happy place, right? You know, because I'm, you know, a mathematician and a computer scientist. So I like that deterministic world, you know. And I push back from things in social sciences and history and things like that because I couldn't relate to that. But fate has a way of forcing you into your uncomfortable spot, and that's where I find myself now, is this I'm into a world where I have to do statistics, which I even as a mathematician, I didn't want to do, you know, the statistics. So you're constantly relearning stuff. Anyway, so let's get into, enough about me. Let's talk about individualized medicine. So the graph you see on the left is it's been around for a while, and what it shows is life expectancy versus how much countries spend on medicine. So you can see the red line, that's the United States, and that's not a very good thing, right? The more we spend on medicine, and we spend far more than other countries, the outcomes aren't improving that much, right? Whereas other nations spend far less and seem to get a lot more life expectancy out of it. So that's just one, you know, life expectancy, just one measure of bang for the buck in medicine, right? So what this really is talking about is, I'm not going to talk about the politics of socialized medicine. That's not the point I'm trying to make here. The point I'm trying to make is our system the medical business really is based on making decisions, right? At the individual level and at the policy level, right? So we make our decisions based on average performance of tests and screenings and things like that. So we calculate we calculate things based on averages. What's good on the average population? If it works on an average in the population, you can expect your outcome to be the same. So there's some uncertainty though there, because just because a certain screening or treatment works for you doesn't necessarily mean it's going to work for me, because my health risks are different than yours. I've got a different health history, so that introduces uncertainty, right? So there's uncertainty whether treatments will be effective. So as a result, we do a bunch of them, right? We try to cover the spectrum. So that's leads us into this fee-for-service and defensive medicine, which is what's causing this red line to be so unattractive, right? So it's driving up the costs, and that's a bad thing. But that's just an indicator of poor outcomes, right? So we're trying things and we're applying medications in situations where we're not really sure if that's the right thing to do. So what we need to do is to move into this area called individualized medicine, and that's what the women's health group at Dell is focused on, studying this using data analytics to try to study this area for women's health, right? So we are a small group, a collection of Viz people, which I am one. Kelly Gaither is also another one. She's the co-lead of the group. We have a physician whose background is maternal fetal medicine and at-risk pregnancy. We have statisticians. We have database guys. So we've collected this kind of eclectic group to see if we can take a crack at looking at data analytics for improved patient outcomes, right? We're not the first to do this, you know. People have thrown more money at this than we are, but we think that we've got sort of an agile, right combination of people to do this sort of thing. So anyway, so what we're doing is we're using data analytics, right? So visualization and analysis, statistical analysis, machine learning sorts of things. And we're looking at this sort of data. So what we're trying to do is get a picture of based on large-scale health data, what really influences outcomes. If you collect, we think if you can collect enough data, you can get a decent picture of the causes and effects of these various treatments, right? So we're looking at the list here goes from CDC data. So we're looking at pregnancy first, right? You know, so that the list of data goes from the CDC data, which is free online. We're trying to get some state Medicaid data, which is not impossible to get, but it's not easy. Electronic health records gets a little more difficult and a little more touchy to handle because, well, HIPAA, right? Those are the available data that we can get, going from easy to get to more difficult to get. And failing that, we're also going to look at collecting our own data using passive monitoring through your phone, and also mining social media sorts of data. So what we're collecting all this data for is so we can find a signal. And we're applying, typical data analysis and machine learning techniques to find that signal. And the goal is to improve outcomes for patients. And we're using visualization for patient communication. You can't make a decision without communicating the issues, right? So, okay, so that's a bunch of background on the group. Let's talk about what we're doing in VR. So Kelly wanted us to cover all the bases. So she said, well, we're going to obtain some VR equipment, and we're going to do VR for women's health. And none of us knew what that meant. So we had to get together and figure out, well, what could we do, So these are the three areas that we're looking at. We're looking at reducing pain in labor and delivery. And well, I shouldn't have called that delivery room experience. That sounds like a horrible carnival ride, but it's more, it's not what you think. It's for dads, right? We're going to give dads the experience, right? A virtual delivery room experience. I'll get into what that actually is in a minute. But then the interesting one is this VR for medical decision aids, right? So this ties into some stuff I saw earlier here, where some women from Australia were telling us about the nursing, and it's really about education, right? Decision aids, well, I'll get into that in a minute. So, but that's a connection. You come here and you think, oh, this is all new stuff. Nobody's doing this. Then you find out, oh, everybody's doing it, So, which is good. It's good. You learn from that, right? These are my cohorts. These are the people that are helping me do the visualization and actual development. Simon is from the Department of Radio, Television, and Film. He has actually done a lot of VR development. He's done work with Hilton to do training for empathy, to train their employees what it feels like to have a crappy experience at the hotel. So you put on the glasses, you go to the desk, and the desk person is just rude to you and just gives you a hard time. And then, because that's the person who's going to be behind the desk, and they want them to understand how valuable it is to have customer service. Anyway, that's one of the things that Simon has done with video capture. Jordan Pike is a new addition to the group. She's a trained statistician and in population health, and has a master's degree in that. But she's also a VR developer and a user of VR. In fact, she knows more about using these systems than I do. So she comes brings great enthusiasm for data analysis, and also what works in VR. She's got a lot of experience with that. So those are my two VR folks. So not a lot of this stuff is actually complete. Okay, so this is preliminary work. We haven't really actually started the pain and in labor and delivery. So it's not to induce pain, but of course, but a VR project to reduce pain in labor. And it turns out that here's a citation. There is a lot of work in that area. Women seem to, and nobody enjoys labor, I don't imagine. That's my speculation anyway. But women take to it. I mean, they put the headset on, it takes them to a beach, and a calming voice talks to them, and they hear the seagulls and everything. And it doesn't take the pain away, but it distracts them, and it makes the time go faster. And before they know it, it's time to push, time to deliver their baby. So this was one of those things where we thought, we're going to be innovative and do this. But no, we were beat to the punch. But we're still going to investigate this and see if we can do a good job and add to the to the situation. Another area where this is popular is burn victims find this very nice. They put the goggles on, and now they're in a snowy scene, and they have to throw snowballs at a snowman that's moving around and that sort of thing. So, but it distracts them from their pain, and it's very effective apparently. Okay, delivery room orientation. That's better than delivery room experience. So the idea here is we also, in addition to being a research group through our physician, we also have a clinic where the analytics that we develop are going to be used to help women actually make decisions, right? So one of the a little aside, one of the analytics things that we did, it turns out that we're studying preterm birth and stillbirth, right? So it turns out that if you're born early, the chances of you succumbing to neonatal death, not living very long, increase. Of course, people know premature babies don't necessarily make it, and the younger you are, the higher the risk is, right? So what people don't realize is if you stay in there too long, if your gestation period goes too long, the risk of stillbirth also goes up. So there's an intersection, and that intersection point it minimizes those two risks, and that gestational age is the right age, for you to be the optimal age for you to give birth, or the optimal gestational age for your baby. The difficulty is, and this is one of those average things, right? They calculate these numbers based on averages, right? So the average population, people will say that the full-term baby is 39 weeks. Well, there's two problems with that. One, it's difficult to actually tell what the gestational age is. There's two ways to do it, through LMP, which is last menstrual period, or there's a clinical way where you get in there with the ultrasound and you measure baby sizes of baby parts, and from there, statistically, you figure out how old the baby is. But you can be a couple of weeks off, so there's uncertainty in there, right? The other thing is there are factors that influence where those two lines intersect, and those are individual factors. Diabetes, do you have diabetes? What's your weight gain? Race, believe it or not, will shift that line a little bit. What's the other one I'm thinking about? Hypertension. If you have hypertension, your optimal point of delivery is going to shift back and forth. And it depends actually, even more complicated, on the combinations of those factors. So that's what we're talking about when we're talking about individual medicine. We're going to, what we have done is we've done that analysis, and then we talk to the patient and we find out what their individual characteristics are, and we show them the graph and say, okay, here's your optimal point of delivery. Of course, it's the woman's choice to, she may make it to that point, she may make it a little beyond that point, but we want to give them that information anyway. Okay, back to delivery room orientation. Since we're doing, keep speeding up because there's 5 minutes to noon, it's lunch. Okay.
I think we started a few minutes late. Okay,
I'll just calm down. This is how I do a thing. It's just momentum. It's like rolling downhill. That's a bad analogy too. Anyway, delivery room orientation. So this is one of the other services we want to give the women who are availing themselves of our clinic. They have this option to use the what we're calling digital health, computational health services that we provide, and this is going to be one of them. And the idea here is, when you're a new mom, especially, you've never seen the inside of a delivery room before. So the idea is to introduce women to the birth environment. Here's where you're going to be having your baby, and we're going to let you experience this in clinic as part of your regular checkup. So they come in, they do their regular checkups, and we're going to offer this window, this virtual window into the delivery room, right? So we think it'll be popular. The idea is to lessen the anxiety. It's just one less unknown for a new mom, and we think that's a valuable thing. In particular, it's helpful for moms that are busy or with limited resources, right? They can make their clinical, checkups, but maybe they can't make it down to the hospital to take the tour. Every hospital will give you the delivery room tour, right? If you like it. It's all part of that birthing thing. So having said that, we've actually done some work on this one. We have two approaches. One is video capture, and that's the one that Simon is helping us with. He's the video guy, and this is his gig. It's got video capture. It's a 360 camera that we use. It's got pretty good resolution, good optical resolution, photorealistic sort of thing. But the neat thing is we can have a human guide in stereo. So we can have, the idea is to either have a doctor or a nurse take you through the room, show you, kind of, this is where you're going to be. All this scary equipment isn't really so scary. Turns out one of them is just a computer, nothing to be afraid of. That sort of thing. The problem is when you're doing the recording, you're pretty much static. So in your virtual world, you can't really, move around and get a look under the bed and all that sort of thing. So to address that, we're also doing the modeled room. Less realistic, more cartoony perhaps, but you have more mobility. So, depth cues are better. You can interact. You'll be able to maybe use the wand and point at the scary equipment and find out for yourself that it's just a computer. But this other one requires time to develop. Here's an image of the capture machine. Looks like some sort of Imperial probe droid or something, but it's got 16 sensors, 360 stereo. I don't know if you're familiar with this equipment. Some of you probably are more familiar with it than I am. This is Simon's, one of the cameras that Simon has. You can go to Live Planet, I guess, and collect that. It does the real-time camera stitching. So they use these for streaming stereo too. So it's got that capability. We also did a surround audio capture, this little cone that fits on top. The software we used was this DaVinci Resolve, Adobe After Effects, and a runner on a Mac Pro. This thing's kind of neat. I'll show you some pictures. It's kind of fun. So for playback, here's our stuff. It's just the usual, VR ready. I went to Dell, clicked VR ready, and said, give me one of those. That's what we had, the two HTC Vive Pro headsets. We got a laptop because we want to be able to go portable and take the experience to places like the clinic and not have to have people come to the health discovery building where we work. That's what the inside of an emergency room what do you call it? One of those rooms. Delivery room, that's it, delivery room. You've got your, scary equipment, your bed. The thing over here on the left on the bottom picture is a baby toaster. It's where they put the babies when they're born. Here's another picture of a different room. There's the baby toaster. So I'm taking pictures of this stuff because this is for the modeling bit. We want to be able to model this stuff, or I'll purchase the assets pre-modeled. So here's some flat panoramic images of what the large room looks like. Here's the stereo, left and right eye. And here's with our nurse. We recruited a nurse. This is at the Seton Hospital downtown in Austin. We're partners with Seton. So we recruited a nurse, and basically you stick this camera in the room and then you leave, and the nurse goes around, and it's remote control through an iPad, so you can watch what's going on. We just say action, and she went around, did her thing. There's the stereo. So here's a bed perspective. We stuck the camera on the bed, and so when you put the headset on, this is what it looks like. If you're going to be delivering, this is kind of what you're going to see. This is your perspective. Let me see if I've got a picture of where they. Oh wait. So in the upper left, you can see the device. It just sits on a tripod there. And the bottom right picture, you can see that's where we captured the bed perspective. So, I go through these. I don't know, how am I doing? I got about 5 minutes left. The model delivery room, of course, it's under development. It'll be a Unity thing. We've got an intern who has some game development. He actually got paid for doing game development, so he's going to help us out with that. our last VR thing is immersion for risk communication. Okay, so we want to communicate possible outcomes of screenings and procedures. So what happens is you consult with your doctor, and they say, okay, you have a enlarged prostate, or your PSA is high. Here's what we can do. Here are the risks of this. Here are the risks of that. What do you want to do? So, you have to communicate the probability of what's going to happen with each outcome, and what the risk or potential harm is to you if something bad goes wrong, right? So we deal with this medical risk, right? So for the model that we're using, we're talking about the risk of unplanned C-section. So should a woman have a C-section, or should she attempt labor? Okay, so there's risk associated with this, right? And at a population-based analysis, 10% of women who attempt labor end up requiring an emergency C-section. Okay? Emergency C-section is much more dangerous, measured in terms of maternal mortality than a planned C-section. So what we're trying to figure out here. So here's a population-based decision. This is a decision tree that we're talking about. On the left, the D is the decision. It's to have a vaginal delivery or to have an elective C-section. So if we travel up the to have a vaginal delivery branch, which is based on the 10% rule, what most doctors advise, you should attempt, right? There's only a 10% chance. So if that's the case, there's a 90% chance that your vaginal delivery will be successful, and a 10% that you're going to require an emergency C-section. If you look up into the decision-making process, you'll see that the maternal mortality is 2.1 out of 100,000 live births for successful vaginal delivery, 90%, and then 10% people who have the emergency C-section. You can see that it's quite high, 18.2 per 100,000 births. Not great. So you calculate the utility. U is the probability times the hazard, if you will. So people who talk about risk in natural hazards talk about this utility. We talk about it in medicine also. And down on the bottom, if the elective C-section has a 5.9 out of 100,000 live births rate of maternal mortality. So it has a utility of 5.9. The average on the top is 3.71. Smaller number, good. That's why people choose the vaginal delivery path. However, that's the population-based story. Okay, if we look closer, as individuals, things come into play. How many babies have you had? Have you had a C-section before? Your weight gain, various other factors, combinations of factors can change that probability, right? So this is the same maternal mortalities, but now if I tell you, you have a 70% chance of having an unplanned cesarean, you can calculate that the expected utility, if you choose to try vaginal delivery, is now up to 13.3, and the preferred, the elective C-section, much lower at 5.9. I advise you to do that. So one might ask, where's the split? Okay, the split comes out about 24%. So if our calculations say you have about a 24% chance of having to have an emergency C-section, your utility is 5.9, and which matches the elective C-section. And then at that point, it's a toss-up, right? I mean, you can go either way. And this is all assuming that people make decisions based on utility, which is not the case. People make decisions based on a whole lot of things, right? So these are all the things that can impact this probability: the age, the race, the weight gain, plurality, how many previous births. So doctors use decision aids to help people figure these things out, right? So as you saw the graphs that I showed you, if I sat down with a mom who who had middle school math, and she's just not going to dig the utility thing, right? She's like, what are all these boxes and circles? She's just not going to like it. She's not going to be comfortable with it. So the idea is to create decision aids that help people make these decisions. Okay. So in the past, these have been like brochure-based things. So when you're talking about risk of medication, you get a fistful of paper when you go to the pharmacist. That's a decision aid, right? That tells you all the risks, every possible thing that can happen. So those are of marginal value, right? They're out there. So recently, people have been using serious games, what they call serious games, to communicate risk and communicate a lot of things, right? So it's a different way of giving information. And the key thing here is that by using a game, it kind of pulls you in and you spend more time with the information, right? You get to do what if sorts of calculations in your head. Well, what if I do this? What if I do that? So that is starting to serious games are starting to find their way into decision aids. They're web-based, pretty much sort of 2D. Here's an example of a game that helps people with prenatal screening, like for Down syndrome and things like that. Do you want to get screened or not? This is the non-invasive DNA sort of screening. They're not, it's kind of like got a Frogger look to it there. So we want to explore the value of immersion. Again, we have no implementation yet. We are in the early stages of developing this rich 3D content, and we're trying to figure out. We're thinking if some immersion is good, some interaction is good, then a lot more will be better, right? A little bit of sugar tastes good, then pour the whole thing on there, right? That's the way it should be. So we're just in the initial throes of putting this together. In fact, I have an R21 that's due in 5 hours, and that's why I'm a little, I'm getting a lot of sleep. Working on that, that has to do with this very thing, to try to set up a VR exploration. Anyway, so that's my spiel. Data analytics, visualization for individualized medicine is good, and we're exploring virtual reality in these 3 areas. And if next year, I would love to come back and show some of the results from that work. Any questions real quick before we dash off to lunch? Yeah.
Thank you so much for your talk. I saw that you are planning to perform user studies at some point once you have something testable.
Yeah.
From the 360 video VR experience you showed us, do you have any kind of preliminary, just bunch of qualitative statements from potential users?
The only that's just that part isn't okay. I have two comments. No, we don't, and because we haven't really showed any of the patients this yet. We have a bunch of sort of test reels that we're doing. We're not really happy with the quality of the video. It's a little pixelated. We want to go to a higher quality camera. So that's the next thing we're going to do when we get back. But the plan is not to do a user survey on that. The user study is for the risk communication. That's where we really think we can make an impact, and that's where we're doing that. This other thing, the delivery room experience, is more of a service sort of thing that we're providing. You can have it if you like, but it's not a bad idea to find out if it was effective in reducing anxiety. That would be great. So that's not a bad idea. Maybe we should just do that.
Thank you.
Yeah.
So microphones here, crickets over there. I don't know.
Yeah.
Thank you.
I hope that's not a cricket isn't a comment on my quality of my talk. It's like, yeah. Yeah.
So one, thank you for being here. Thank Bill for making the introduction. And I think, as Elise commented, it's really fun to see people's work evolve, and the reflection here you shared with your 5-hour deadline too, is how many hats people sometimes wear in this work, and what the juggling act is to really get things, if not across the finish line than across the learning line.
Mhm.
And we also hear a lot of that here. So thank you for the early reflections you provided in this app.
You're welcome.
My question is, will you promise to submit next year so we can see the space?
I will indeed. Like I said, I find this, this is an amazing little hidden thing, and I'm torn between going out in the world and saying, hey, this, and saying, no, this is my own little, because if it gets too big, then it's going to suck, right? There's 10 million people. But what you might think of doing is having different locations. The academic part of it is really cool. It brings academics together, librarians, artists, all of that thing together. And coming to Bloomington, it's beautiful here. It was worth coming. But I can see other things across the country if you wanted to expand local, that crossed my mind as I was sitting there. But yeah, I really,
We'll probably be
I will.
looking for a site for next year at some point.
Well, Austin, Texas. I'm just saying.
That it comes with a host. The site has to come with a host.
I will do that. I'll be happy to host it down there.
Yeah.
Yeah, and I'm being recorded too, right?
Yeah.
So you've got it.
A really quick comment, please. Thank you for your presentation.
Okay.
Just upon reflection, 12 years ago, I had to take half the day off work to go and see a delivery room. And I remember being disappointed I had to take half a day off work. It was a 5-mile drive. It was a 2-hour commute to get to the hospital and back.
Yeah.
And I knew I was going to stand in the room, probably be too intimidated to actually touch anything or ask many questions with a bunch of other stressed pregnant women. And I wasn't looking forward to going and doing that, straight enough. And at the time, I had colleagues that were developing virtual simulators for linear accelerator machines in hospitals. And they were building these VR simulators and giving patients the experience of being able to go and visit the virtual linear accelerator prior to treatment. Not even necessarily to see it on, but just to see the room, to see the equipment, so their stress levels would come down. And they were really angry, sitting there thinking, why can't we just have a virtual delivery room, because it'd be great.
Well,
just sit there and look at a few locations and get environments. And I'm not going to have to pay the equivalent, I kid you not, of about $20 parking for 3 hours.
Well, see, and you were mobile. See, I know if we're gonna have women that are 40% of the births are paid for by Medicaid. 40% of the births in this country are Medicaid. So that indicates that these people are not well. They don't have their transportation probably. They're riding the bus. Right, nobody wants to ride the bus down to the hospital to go through one of those things.
Especially they're like 7 months pregnant or something.
Yeah, right. Yeah, right. It's I take public transportation because I'm lucky the bus goes right where I need to go, and it's not bad. It's great, but these women are busy, right? They have jobs, they have families. Some of them they have and we just think this would be a sort of a great service. The hospital that we recorded this at used to have one of those online, do the 360 sort of tour, but then Ascension bought them. And all of that went away for some reason. I mean, you can still go to the hospital and take the tour, but a lot of their online experience stuff disappeared for some reason. I don't know. It's the evil healthcare, monsters, right? Anyway, thanks for that comment. But that gives me confidence that this will be a worthwhile thing. Any other questions? I release you to lunch.
All right. Thank you, Dave.